Today I'm going to be talking about the interdisciplinary case study. This is discussing Pamela and the different factors about her team effort to get her rehabilitated. So for Pamela, the role of each specific discipline begins with the speech therapist's role, which is focusing on the difficulty swallowing and how that's actually impacting her lack of appetite, as well as the influence of that large weight loss that she recently experienced. Associated with chemotherapy, there's often a loss of appetite, so that can be attributing to it, but we know that she also has difficulty with swallowing, and she is quoted as saying that it's hard to do, so that's something the speech therapist would address and really focus on what is going on with that swallowing process and if there's anything that needs to be looked at further. In addition, the speech therapist is going to also work with the OT to determine the most appropriate adaptation to her silverware, because it's quoted as being difficult for her to manipulate the silverware and for her to use that during the eating process. So it's also important that the speech therapist prioritizes finding the most appropriate foods and restricting her diet or adapting her diet in order to ease that eating process so she can consume the right amount of calories. The role of the physical therapist with this client is to continue addressing activity tolerance. Lower extremity strength has been noted as being decreased due to that chemotherapy. So if that chemotherapy is now finished, working on rehabilitating that lower extremity strength will help increase her activity tolerance. As well as they talked about introducing the forward wheel walker, and she was successful with ambulating with that, and so continuing to educate and work on proper ambulation with that equipment for safety as well as for increasing the distance she's able to ambulate. Another thing the PT would work on is the pain management strategies. So that could be breathing, different adaptations to her movement that can reduce the pain. Looking at some of those things can be introduced by the PT as well. So finally, the role of the occupational therapy with this is that they're also concerned about strength in her activity endurance, more associated with upper extremity, but also concerned with safety of ambulation with the walker. Working on education with that as well, making sure that when they are ambulating to the bathroom, she's using that appropriately. And then she's noted to have a lot of difficulty with self-care. That's associated with manipulation of the objects that she needs to use, as well as just endurance and being able to complete those independently. So that would be a huge area that the OT would focus on, making sure that ADLs and IADLs are able to be completed with as much independence as possible to take some of that burden off of her husband as the caregiver. In addition, the OT would work on endurance during those tasks, so working up on how long she's able to stand while doing them versus just sitting at edge of bed. Working with the other disciplines to adapt different tasks such as eating, as I mentioned, using the different silverware, things like that. So the OT's role is really to work as with all the areas in order to make sure that she's able to complete those ADLs, IADLs, and has the appropriate activity tolerance. And then I mentioned pain management strategies for the PT. That's also with OT. OT can work on pain management strategies at rest, during those activities, when she's taking breaks, or whatever that may be. And then the importance that they all work together. As I mentioned a little bit before, it's important that all the professions work together because many of Pamela's concerns touch on every area of all three disciplines. So it's important for the speech therapist and the OT to work on adaptive silverware, making sure that the frustrations associated with that task are limited, and that she's able to use those adaptive devices independently to help improve her independence with those functional tasks. It's also important that while the speech therapist is working on swallowing and working on those things, the functional things or the structural things, the OT can be working on looking at how she's able to grasp, how she's able to see her whole plate, all of those things, just making sure that she's educated properly on that as well. So then the OT and the PT can work together on endurance and activity tolerance, working on safety of use of adaptive equipment, working on what happens when they ambulate to the bathroom, potentially working together to ambulate safely and then also complete that functional task. So the primary focus of the OT is ADLs and IADLs, and the PT would primarily be worried about strength and function of ambulation, but they can work together to kind of incorporate those together. And discussing the idea of a co-treat, I think that an idea of the co-treat for the OT and the speech therapist would be really beneficial, as I mentioned, during a mealtime using that adaptive equipment, having the OT focus on how to do that, while the speech therapist is working on the structural component of swallowing and making sure that the client is able to do that as well. For the OT and PT, I think it would also be beneficial for a co-treat, especially early on, because Pamela is noted as saying she already saw OT. So there could be some frustration associated with not understanding the role of each. And so having a co-treat could provide the opportunity for education on what each one is able to do, as well as getting that person up and walking, but then also completing a functional task. So incorporating that PT and OT at the same time to help encourage her to be more active, but also keeping in mind that her activity tolerance is lower currently, so working up and building that would be important. It would also be good for the OT to see how the PT wants her to use the forward wheel walker, and for the PT to see how she wants her to do the bathroom routine. So all of those things would be really good for communication between the OT and the PT. So then some functional goals overlapping between the different areas. As we mentioned, OT, PT, and speech all have the same common goal of getting that client rehabilitated back to her prior level of function, gaining independence with her functional tasks, being able to eat, walk, go to the bathroom. All of those things are so important for independence, and so they all have that common goal. And so the OT is really kind of the key feature of those ADL tasks, but they all have a common goal of getting her back to that and being able to engage in those things. The speech therapist and the OT both want to see the client succeed with self-feeding and meet those nutritional needs to decrease the weight loss and to enjoy eating again. And then just making sure that the PT and OT are both on the same page about safety, knowledge, education, and present as a united force or a united front. And so, yes, that would be how the functional goals overlap. They all kind of want to see that independence and increasing activity tolerance, increasing ability with self-feeding, self-care, all of those things. Communication with the other disciplines, such as the nursing and the family, all of that is really important because frequent and consistent communication is always important with other disciplines in order to present as a united force, or a united front, as I mentioned before. So discussing that what interventions the OT is doing with the other disciplines is important because it's important that the speech therapist knows what type of adaptive equipment that the OT recommends and what they use, so that then when the speech therapist goes in and the OT goes in, they're on the same page with that client. The client feels as if they're in good communication about what the client should be doing. In this case, Pamela. And so that also goes with the OT to the PT, knowing that they're using a front wheel walker and that's a new equipment would be beneficial, because if the client's not 100% comfortable with that forward wheel walker, the OT would need to know, okay, this is something I need to focus on and re-educate, versus if they think that it's something they've always been using, then the OT wouldn't emphasize on that. So presenting with the communication with other disciplines is really important for the client's safety, for the client's success, and also just for the client's experience in the hospital. That goes with nursing and family as well. The nurses need to understand what different interventions are being done, because it may not always be the OT who goes in for the bathroom routine, or for if the client wants to brush their teeth in the morning. Those may be done by the nursing staff or by other members of the medical team. And so the OT needs to be in good communication, and all the disciplines need to be in good communication, so that the client's experience is not feeling like they're not being heard and not feeling like they need to constantly re-educate the team members, where it should be the other way around. Same goes with the family. Helping her husband understand what the things that the team is doing can help him later on, as that is carried over into whatever facility she transfers to, or if she transfers home, so that he knows what care she needs and what care he can have her be doing and how they can work to increase her independence. So it's just really good to present as a common ground, and everybody's on the same page in terms of communication, so that the client feels safe, cared for, and heard, as well as the family feels like their family member is being prioritized, and so that's important too. So I don't believe that necessarily one member of the team is more valuable than the other, because I think that creates the mindset that one is superior, and I don't think that's necessarily the case. I think in this situation, OT is very relevant because they're that common ground of ADL, IDL, which we know that Pamela has a lot of difficulty with those things, and that's a really big priority for getting her back home. So the OT, I think, is kind of the core of this team in the sense that they can work with the PT and the speech therapist to develop those plans of care and to be on the same page and to provide the best care for Pamela, because we know that that united front can help Pamela reach success faster, because they're all going to be working on the same things. It's just how they're going to be working on them is going to be different. So the OT really needs to play a key role in this situation in order to educate and work with her team members to make sure that the adaptive equipment is appropriate, that the activity tolerance is being increased, all of those things. So I think the OT is one of the most relevant and probably the most relevant, but again, I want to make sure that everybody's on an equal playing field, so because I think that's important for a team dynamic. Some various intervention plan ideas for Pamela would be for speech therapists working on that self-feeding, meal times, and making sure that the introduction of this adaptive equipment goes smoothly. All of that, and then potentially a swallow study if that's not already been completed to make sure that everything is okay structurally. That would be another intervention, as well as food modification and diet education. So some ways to grade that up is just with the self-feeding and the introduction of adaptive equipment for utensils, less education for the client when it comes to how to use those as she progresses with that. That would be grading it up, having her be more independent with that, as well as with self-feeding, having her initiate those things. All of that can help to grade that up and make it more difficult, as well as grading down would be doing hand over hand as she learns to manipulate that adaptive equipment, and as she learns to self-feed, maybe using your hand over hand to aid in the transfer of the food from the plate to the mouth, things like that. As well as for OT interventions, working on independence with ADLs such as bathing, toileting, eating, grooming, hygiene, dressing, bed mobility. All of those things are really key features of ADL and IADL tasks, and so any of those could be considered an intervention. Activity endurance would be an intervention opportunity, applying that to one of those ADLs, as well as using the adaptive equipment and working on in-hand manipulation skills. So let's focus on one of those ADL tasks. We'll do toileting. So to grade that up, toileting would be done with obviously less support from the therapist, less cueing from the therapist, having the client take on more roles such as doing the hygiene care, doing the actual transfer more independently, transferring from walker to toilet, less cues in that situation as well. All of those things would be grading it up, and then grading it down would be the therapist is there each step of the way, cueing with hands-on assistance. They're the ones taking care of the toileting, hygiene. So those are all ways to grade that up, or grade that down, sorry. So then lastly, the physical therapist, some intervention ideas for them would be ambulation distance, activity endurance, use of adaptive equipment, functional mobility, increasing strength, so that would be like range of motion and strength exercises, as well as transfers. So all of those are intervention ideas for physical therapists. So let's talk about transfers. So currently she's doing a lot of activity at edge of bed, but she is able to ambulate using that forward wheel walker. So I would say transferring from edge of bed to the walker would be a great intervention opportunity, and potentially having her ambulate down the hallway or over to a chair. So for grading that up, it would be increasing the distance that she's able to walk. So that may be a lap around the floor if she's really getting that down as she increases from that 15-foot distance that she's able to ambulate. And then grading that down would be shortening that distance, having her just walk to the toilet, having her just walk over to her chair. Things like that would be grading that down. And then in addition, during the transfer, the physical therapist hands-on approach, are they min assist? Are they mod assist? Are they max assist? So grading that up in terms of hands-on help as well would be important for grading up and grading down. So that's really all I have. I think that this would be a great opportunity for all three disciplines to come together and really have a common ground and work together to give Pamela the best care. Thanks.